Hello, ladies. We are and gentlemen. We are discussing chapter 15, and these are priorities for the preoperative client, okay, or patient, the pre-operative patient. Next slide. All right. So there are three phases to an operative experiences, right? So when a patient is about to go into surgery, there's three phases, and it's really, really important because we want the surgery to go well, and we want the patient to come out of it successfully with no complication. So your priority is to complete a preoperative, checklist for pre-operation, right? And each facility have its own unique checklist, so it's really important to ensure that the necessary documentation, admission assessment, physical preparation, and educational needs have been completed prior to the patient entering the surgical suite. So the operation experience consists of three phases. Pretty much that's what this is saying. Preoperative, intraoperative, and postoperative. So pre before the operation, during the operation, and after the operation. So caring for the client's physical preparation, like I said, and mental and spiritual preparation is critical. Before the patient goes into surgery, you can already see what possible nursing diagnosis you can be thinking about, right? So anxiety, right? Anxiety of not knowing the outcome, anxiety of not knowing, what the surgery is, anxiety of not knowing if they understand what is being said. So a whole bunch of anxiety, and it's our job to make sure that we provide all the information that we need, because knowledge would help to decrease anxiety. Correct? Next slide. So our slide right now, the next slide is talking about informed consent. Informed consent, all right? So informed consent is really, really important, and it's when a patient, autonomously, that's the key word, the patient autonomously and cognitively, right? So those are two things. They're making the decision themselves, and they're cognitively aware, therefore granting permission to a provider to perform a surgical procedure after they have considered all the alternatives. So rather than doing the surgery, you could have done this: the benefits of the surgery and all the risk of the procedure. If the patient does not autonomously and cognitively grant permission, then consent is not reached, right? Consent is not reached, right? What is your role? Your role as a nurse is not to obtain the consent. It is not. So obtaining consent is not the role of the nurse, but that of the provider. It is, however, your responsibility to ensure that the patient has all the information needed. So all the information they need to make sure that they understand what's taking place, to make an informed decision about the procedure. Because the patient has the right to refuse a surgical intervention, right? So even when death is a risk of refusal, yes, they can. You also need to, because they have the right to refuse, you got to make sure that they have all the necessary information to make an informed decision. Next slide. All right. So, what are the components of an informed consent? Component of an informed consent include: there's a name, there's a type, and it's the reason for the surgery. Right? The name of the surgeon to perform the surgery, right? Because you want to know it's not, the guy next door that is just performing any type of surgery on you, right? The reason that intervention will benefit this patient, any alternative options to the surgery, potential outcome if the surgery is not performed. So, you have breast cancer, the biopsy says so. If you decide not to remove the breast or do other treatment, what could happen, right? Consent for anesthesia, right? Because we need to make sure that the patient is comfortable during the procedure, right? And not in pain, right? Consent to administer any blood product. It's important because it's possible that they may lose blood, or maybe they have transfused or donate their own blood, previously, or they could be a Jehovah's Witness where they don't want blood. So it's really critical that we assess all of this, right? So, inability to consent. Some folks are not able to consent, right? So, special consideration when the patient is not able to consent for his or her care. So, if you're not able to consent, then it's going to imply that you're giving us consent, like in a surgery, right? The role of the surgeon, again, is to obtain the consent for the procedure. The surgeon is solely responsible for obtaining the consent in the presence of the patient and one witness, and usually the witness is the nurse, right? So the role of the preoperative nurse is to clarify, information and ensure that the patient understands, okay? So you're an advocate. In obtaining, reviewing the consent form and validating the patient understand, the nurse often serves as the witness to the consent, right? Next slide. Timeout, pause for cause, right? Timeout, pause for cause. So what happens is the surgeon marks the surgical site with his or her signature using a permanent marker, right? Some surgeons may require that, if possible, the patient marks the site herself or himself, right? So the timeout or pause for cause starts when the patient enters the surgical facility. So the patient receives a wristband containing identifying information upon admission, you know what I mean? And then confirms that all the information is correct. And then the timeout is performed again by circulating nurse upon transfer to surgical unit, right? So immediately proceeding session by the entire team. So we just want to make sure, are we really removing the leg we should be removing, right? So if you have a mark on it, then it's most likely that it's not going to be a mistake, right? It protects the patient, it protects the people that are involved in the process, right? Next slide. So what are the components of a timeout? Okay, so process may vary in different facility, right? Components of timeout are usually consistent, right? Performing a timeout immediately prior to incision makes an irreversible mistake less likely. My goodness, right? Just imagine that the wrong leg is removed, or something simple like removal of the mole versus removing an arm, right? So the nurse should remain with the patient that this information is important in providing safety. Remind the patient that. It is also important, as a role to ensure that the patient that no judgment will be made on his or her response and that the information will be used only for medical purposes. All right, next slide. So to go into surgery is really important. So a complete medical history, complete surgical history, complete social history, it's really, really important, right? So as the nurse, you're going to ask a lot of questions, a lot of pertinent questions of the patient's medical history, right? He or she should be taking special notes of any condition that will pose a risk during the surgical procedure, right? So you're gathering this information so that you're able to know, okay, what is in this patient's medical history that may tell me that, complication may come. So you want to find out about history of diabetes, any immunodeficiency, right? Any risk for poor wound healing, right? Because if you're going to surgery, you need to heal. And if you're already at risk for not healing well, that's a problem, right? You want to find out, is there any implants, in the joint, dental, or anything that can interfere with the positioning during surgery or intubation, right? So also find out about the patient's surgical and anesthesia history. Very important to know if there's any anesthesia reaction, right? So previous surgery may also have left a scar. So as you're assessing, you can look and see if there's a scar that is available, that is there. Any internal adhesions, any medical implants that may be considered. Also, you're looking at the age of the patient. So the age is important for a magnitude of reason, right? So the older patients already have delayed wound healing, right? Their skin is frail. They may have nutritional deficits. They may have a decrease in, immune system function. They have a decrease in renal and hepatic function. They have other chronic conditions, and medication that they're taking, or they have decreasing mobility. So it's really, really important to look at that. Allergies is also another area you need to look at. So all patient allergies must be documented, right? And it's not just document the allergies, it's document the reaction to it as well. So do they have allergies to medicine? Do they have allergies to food, medical medicine or medications or medical dyes or latex? Very important. Any medical adhesive or environmental condition, on and on, that can create a problem. Next slide. So you also, as part of the history, you want to look at the medication that they're taking. So current medication, extremely important as part of the preoperative, history. Really important, because there's certain drugs that shouldn't be taken before surgery, right? The last oral intake, it's important, right? Because they're going to have anesthesia. You don't want aspiration, right? So guidance may be modified or different for population, right? So usually there's nothing to eat or NPO for at least 8 hours prior to the procedure, right? Alcohol, smoking, and drug use is also another things that we need to worry about, right? So you want to make sure that smoking and drinking sometimes are comfortable, but important questions to ask, the patient. So any special consideration, some questions may require privacy because of their sensitive nature. All psychosocial questions such as abuse at home and any gynecological and mental illness questions. All this, you need to be cautious of that. All right, next slide. Advanced directive. It's really important to have an advanced directive, especially when you're going into surgery. But the Patient Self-Determination Act of 1991 grants all patients the right to determine and direct their care in times of medical emergency. That makes sense, right? The right is to create an advanced directive in advance, like advanced direction, right? So within the advanced directive, the patient may name a durable medical power of attorney, so they can name someone, usually a spouse or an adult child, who is designated to make all the medical decisions should the patient become incompetent. And that only happens if the patient is not able to, right? Right? So the patient may need to have all necessary measures taken, right? So I want you to do CPR, I want you to intubate me, right? Or they can choose to say, you know what, I want to limit it. So do not resuscitate. So I don't want to be resuscitated, right? So DNR, DNI, or I want everything done, right? So allows the patient to express, also the desire about their organs. If something happens to me, I want my organs removed, right? In end of life issues. Next slide. So assessment. It's really important. So another component for preoperative, assessment workup, right? So the assessment part. So you've gotten the history, all of the different things, and now you want to go through physical assessment. Physical assessment has 4 techniques. So you collect the data, right? After you're done with data, you're going to inspect, auscultate, percuss, and palpate, right? So assessment parameters, you want to look at the patient's height and weight, right? It's going to help because some drugs require the weight, right? So anesthesia provides determined fluid needs, and then we want to know how much fluid they need and how many drug doses they need, antibiotic therapy. Vital signs are obtained by the nurse during the initial assessment. It's really important. It gives us a baseline, right? The baseline of the current blood pressure, respiratory, pulse, temperature, and pulse ox. It's really important to see where they are at this time. Next slide. And then making sure that each of the systems are assessed. So cardiovascular assessment, right? So in addition to the pulse and the pressure that they've taken, the nurse would assess the cardiovascular health. So we'll listen to the heart and, any abnormal sounds, murmur, 3rd, or 4th heart sounds, right? It will palpate the pulses, so peripheral pulses, especially making sure that the skin is warm, the color of it, making sure that there's, good skin turgor, making sure capillary refill is there. It's less than 3 seconds. Temperature and edema, noting for any parameters to assess. And then, of course, the nurse would also assess the respiratory system, the breathing rate, the depth, the rhythm, and any adventitious sounds such as crackles, ronchi, or wheezing. Pulse ox, is also used to assess the saturation. It's really important. Neurologically, the nurse is also going to assess, to see that the patient is able to understand, the commands in a proper and important proper to general anesthesia. The nurse also assess the movement, the strength, and sensations of the extremities, right? And then the skin, and then GI system, especially if it's a GI tract. If it's a GI surgery, you got to make sure, that that it's important for the nurse to know any normal bowel habits of the patient, especially if you're admitted in the hospital after the surgery, right? So document any normal bowel sounds. And the nurse assessing again the general skin, so the appearance of the skin, is it impaired or not, and the hygiene. The patient would also, the nurse would also assess, making sure that the liver and renal assessment are there. So any potential renal or liver diseases, right? Maybe there's a Foley catheter in place, making sure that we assess the urinary output, right? Indwelling catheter, when you go on under surgery, you usually have to have an indwelling catheter. The nurse should have the patient void before entering the operating suite and note any unusual order, color, right? So before they go in, it's really important to know the baseline of where things are, right? Because if they're urinating blood and it was there before and you didn't know that, so the question is, where did it come from? It makes things a little difficult. All right, next slide. So preparation for surgical experience. So laboratory. So, you do some lab work. So you should really tap and screen. It's important. So preoperatively, we want to determine the readiness. So, so we need to do a tap and screen. We may need to do other radiographical imaging, MRI, CT scan, ultrasound, X-ray, and you definitely want to do like a EKG for a patient over 50. Just to make sure that there's no underlying cardiac arrhythmias. Teaching patient is really important because surgery creates anxiety, so we want to help decrease the anxiety, which has been shown to improve the patient outcome. All right, next slide. So physical preparation, so you're going to make sure that there's an intravenous line, so it's inserted, preoperatively, because you want to have access, right? So access for anesthesia, for fluid during surgery, and it's usually a large gauge, like 18 gauge catheter is preferred because the size is required to administration of all blood product. Bowel and bladder preparation. So if it's an abdominal, intestinal, or gynecological or rectal surgery, they may be asked to perform a bowel prep, right, to prep the area so that to avoid infection. It may be done. So we usually give maybe enema or gentle laxative that the patient themselves can administer at home the night before the procedure. And skin preparation is also something that is done. So prior to surgery, the skin prep is done to help, of course, prevent infection at the surgical site. Patient may also be instructed to shower with betadine, soap prior to admission, right? And then, of course, medication, preoperative medication may be required. So patient with preoperative anxiety may be prescribed a benzodiazepine, right? So definitely you're not going to give them the benzodiazepine and then say, here, can you I'm going to witness the consent, right? Because you want to do that. So before transporting the patient, must make sure that the consent are all been signed. There's history, so like that pre-op checklist is all in the chart for the patient, that all their learning, all the questions that have been asked, they're ready to go. So we're not transporting the patient unless we know that the patient is ready to go. All right. Next slide. All right, so anxiety, pre-op. So this is before the patient goes. So clearly we talked about some of the nursing diagnosis already in the beginning, but just to sum it up again, pre-op is patient going into surgery. So you've got to get a lot of information about them. Talk to them, sit and talk to them. So get the subjective data, get information about their current issues, their past medical history, past surgical history, their lifestyle, their medication. So you talk to them, and then you do your physical exam, right? And you make sure that the consent, that they have all their questions answered for the consent, right? You make sure that they're healthy to go into surgery. If they're not healthy, complications may occur. So in the process of that, you're going to see there are some nursing diagnoses that is very pertinent. So a very, two big ones are fear and anxiety and a knowledge deficit, right? Fear and anxiety related to what? The loss of control and not knowing, right? Or knowledge deficit because, due to the treatment procedure, right? So what are some interventions for these? Vital signs, OCT to SAT, physical exam, last oral intake, confirm skin and prep, remove jewelry, time out, review what to expect. All right? So that ends chapter 15, priorities for preoperative patient care. All right?